name's Fenton. I've been at St George's looking after the technology since about 2018. I've got Erin Bensley here. She's the clinical informatics manager. We've worked closely together for the last 7 years, part of this journey that we're going to go through today. This is a wee video of where St George's is in Christchurch, New Zealand. Private hospital. So it wasn't always like that. George was established in 1928, just under 100 years ago. It was established for the people in Canterbury, in the region, around healthcare and support. We're a charitable trust, which is we get non-profit, so we're able to put funds back into our facility, our people, and obviously the care that we give our patients. Going back to that building up the top there, that was one of the first historic building we had. In 2010, we had a Christchurch earthquake, if you remember. That was damaged to the point that we had to pull it down, and that's when we had that new facility now. Not all of it, but a part of that was rebuilt. So we've got a very nice facility, and it does us very well. The size of our facility, we've got 115 beds, we've got 13 theatres, so we've got a wide range of services that we provide to the public. What we're going to do today is we're going to take you through our digital transformation journey. It started way back in 2006 here, but 2005, Darren Jones, sitting over here, he was over in Christchurch, and he sold that to St George's back then. I wasn't there, but initial development, then through to the EMR capability. I'll put these on. That's when we decided we need to digitise more, and we're looking at how we can move things forward. And then the New Zealand edition upgrade, I think Ken was talking before about that. We went through this a couple of years ago, and then now where we are today, we're upgraded. Now we're ready to optimise and take on the new functionality and things. So I'll hand over to Erin now.
Kia ora koutou. So I am Erin. I'm Clinical Informatics Manager. I've been at St George's. I have a nurse's background. I've been at St George's for quite a while before I went into this role in 2017. But I was that person that was always seconded to change projects and went on a bit of a digital health journey. Similar to every people that we've heard today, when we started out in that 2006, neither of us were there, but it was really around patient administration and really key, especially for private hospitals, billing, getting to that billing point of view, and everything was designed in that space, and not for clinical. For clinical areas. We were one of the first in New Zealand, I think, to implement TrakCare. So one of the privileges of that is you can configure it however you like. And that happened, like we talked about before, what we've heard already is that happened over 20 years, and we just layered and layered and layered and layered on top of it. So our clinical staff were extremely involved in data collection that didn't add value that could be easily seen to actually the patients that we were providing care for. That's where we went on the next part of our journey. So we started to look at electronic health record in 2018. Obviously, strategic decision to digitise our clinical records. All of the reasons, improve efficiency, accuracy and patient care that we've heard about. And we started with a comprehensive review, and our preference was to use TrakCare. So we went through this process of identifying our requirements and decided that TrakCare wasn't going to work for us at that point in time. And there's people here that were involved in that as well. So we did choose a different solution, what was always going to be an interim solution until we started to see what was coming in TrakCare. and we implemented. So we've got, so in 2019 actually with the other solution we were able to roll out our clinical digital record, and 80% we're at now of that being digital. Now we're into the next part, I guess, where we start to look at circling back to TrakCare. Yeah, so I'll let you talk a little bit about that.
Yeah. So I think it was back in 2020 there, we were having, I'd been on board for a couple of years. We're having problems around supporting, updating, things breaking. People could change change the system and the production without into test. So we're getting the environments all out of whack. And as you see here, we've got the objective. So InterSystems came to us and said we were looking at making an edition, New Zealand edition for private hospitals. I think they've been working with Levia or MCS Scott at the time, and come to a solution that would fit into our to replace our current bespoke view of the world. So key there was streamlining our upgrades, providing a new interface, modern interface, ensuring compliance, because there's a lot of compliance we have to all apply by, and easier to support for InterSystems, and then secondly for us as well. And down here below is very similar things there. We customised. We didn't have any documentation. People would leave and we couldn't know what was configured. So when we did the upgrade, it would break. So that was where we made the decision. Yeah, that's a great idea, and let's get on board and let's start planning for that upgrade. So the approach, again, we talked with InterSystems, come up with a really good commercial agreement and a plan that would work for both of us. We both wanted to get there, the same objectives. And the key there was, InterSystems came and gave us a really good team around functionally and the support around the project. And we had those roles really defined, which made a big difference to us. And on our side of the teams, Erin was crucial around the clinical side of all the processes that we had to work through that change. So again, that setup of that project structure was crucial for us. So we had people involved from the wards, from the theatres, from finance, and the admission side of things as well. Moving to the bottom there. So pre that, they got into a health check. So that was really around understanding what we had in enough detail so we know it was ahead of us. It was a big change. We knew it was going to be a big change, but how big? So that was crucial around there. So then that was our start of our journey there.
Awesome. So the big part, the massive part, I think the thing that you need to spend most of your time on was really looking at our current state, understanding our current state, take the technology out of it and really get a good understanding of that current state, why we do things, how we do things. We'd lost all of the knowledge, people that had worked with TrakCare just before, not long before we came into this. So there is a little bit of an advantage that you are looking at it with a fresh lens, but also trying to understand why we did something in a certain way. We had 363 gap items. I won't say this wasn't a negative thing, but it was the difference. And some were big and some were small. And I do want to say ngā mihi nui ki a koe, Greg, for your snapshot of Aotearoa. We obviously are in a very different environment down in St George's Hospital in Otatahi, but one of the other pōtai I wear, being a direct product of the active partnership between Pākehā and Māori, is around Māori health. So obviously an important space for me, and I had to be patient. The equity framework, we were waiting for that to come from Tamaki Makaurau, so grateful. I did have a conversation when we were talking the other week with InterSystems, and I got told my gender issue was resolved, and it's not my personal gender issue, but that sort of gives a bit of a feel of where I played a part in that aspect. So every gap was reviewed, discussed, we brought in the clinical teams. Like, is this like someone mentioned perceived loss of functionality, or is it true? And you know, do we need to actually go back, refine our internal practices? They're also being established over many, many years as well, and things put in place. This gave us the opportunity to look at all of it. So the whiteboards that we created did not look like this. I'm sure we've all had our very messy whiteboards and post-it notes and things like that, but this is what we did through, you know, all of our points through our service. Feels like it should be easy when we're much smaller on the scale that we've been talking about today, but yeah, it wasn't. So the key parts, and we've had a look at this, is that functional testing. So once we'd done our current state, we started to look at what it is, what our workflows were going to look like, and we created these test scenarios, 28 test scenarios from end to end that would match our, will cover everything that we needed to cover. So these were the things, every time we had an iteration, these were the scenarios that we used, and could identify anything. Quite strict on making sure we did every single scenario in that space, and then we could limit it down to cut over to just 4 scenarios to ensure. We started to bring in more staff, smaller scale, very small team. I was really jealous looking at Alice Springs and Tamaki Makaurau and all the smiling faces and our little office.
Just the 2 of us? No.
Yeah, yeah, 2 or 3 more. But yeah, now I want to come and work in Alice Springs, to be fair. Still got my practicing certificate. So that was really important part of, and that was how we brought the team in. We didn't have the workforce that we could pull people out to work on it over time. So doing that testing in the different spaces, having them involved in those scenario testing in the areas was really important. And then developing the staff training out of that. The comprehensive documentation that people have talked about, setting up our training rooms, similar, drop-in areas. We're only one site, so we have that advantage that that's a bit easier for us. And then quick reference guides, and really I think what's been really key is our really short instructional videos. So just that function, 2 minutes, that someone can go find, pick up and watch. And just getting rid of all the other stuff that's out there that people have designed for themselves. Although we did find one the other day. We can rip it up. Yeah, so that was, I guess that's the main approach that we took with the implementation of Edition.
Yeah, and just to extend on that functional testing, those scenarios, we did months of that because we'd get fixes, we'd have to retest, and it made it easier with the detailed test scripts that we had. And those scripts are still used today. So we can do easy upgrades now, 2 or 3 times a year, and it's a very different to what it was 3 or 4 years ago. So it's great. Go live cutover. So this is over I think it was 15 months, 15 to 18 months. And when we got to the point where the system was right, we had the infrastructure all set up, we had the test runs through, we had everything in place. We had a run sheet for the go live cutover, and one of the big points there was around the data. We had a shorter time possible to do the cutover, so the system wasn't being able to be used, but we had a whole lot of data from 20 years. So we made the decision to bring the data across early, and then the last 3 days just bring the delta across and update it. So when at 4 o'clock on the Friday, we turned the system off, and InterSystems took over, did their upgrade, gave it back to us midday on Saturday, and then we ran through our testing and all the different things that we had to do. So that was really crucial. It was really detailed down to check-ins, everyone's signing these off. Yeah, that was what was successful, I think, cutover. So all the way through there too is through that cutover we evaluated the risks and the contingencies as well, because we had to have the clinical staff being able to look after the patients in the hospital still as well over that weekend. And yeah, as I said there, the cutover was Monday to Friday to Monday, and we were ready to go on Sunday midday, and obviously we did checks and other things on the way through, but yeah, we were very happy with that. So benefits, at the very beginning, we had those things that we wanted to try and achieve. I think we did that and more as well. So regular, I think I've already said that actually, regular easy system upgrades, we do that 2 or 3 times a year. Testing is nice and easy, so we get the people in the functional areas that own the functions to test their own stuff, but they're structured test scripts, so they just don't go off and just test randomly. And change management, we've put CCR in for change management, and that's made a big difference for us as well, so we can test through the different environments and we know it's going to be right when it gets into production.
The other benefits, of course, when we started to look at our standardised workflows, so take technology away, like we've talked about, and started to really understand why we're doing things as an organisation. And I've liked, when people talk about it's a change project, not a technology project. And when you do it well, there's huge benefits from it. We introduced the user-friendly interface. We made a specific decision to do this. We couldn't do it for all departments because of NHI compliance things. I don't know how to explain it. But so we couldn't do it for all our clients. So we did it where we could, and this was specifically into our clinical areas. Really, really stoked that we made that decision at that time. And I was talking to someone earlier, because now that whole change in interface as we go into our fire implementation, our clinical areas, which is 80% of our workforce, have already been using the mobile enhanced user interface. Comprehensive training, doing everything the same way, knowing why we're doing things, and just, has had a huge advantages across the organisation, I think.
Yeah. And then I suppose finish the upgrades regularly through the years, the last year and a half. Now we're in a great position that we can start to take on that functions that InterSystems are releasing on a regular basis. We've been working on our upgrade to fire and the admission part of the system to go to the user interface, and the finance side as well. So that's our last bit there. So that'll be a big new interface across the whole system, and then we can start optimizing as well our current current system and looking in detail what we're doing, why we're doing it, and then moving on from there.
I guess we've talked about optimising our current functionality, but now we're looking at going back and our clinical, introducing the clinical module. So once we've done our fire implementation, we're in a really good space to look at doing that, and excited about it. Our clinicians don't work for us. They're starting to bring products to us that they want to work in our environment. So we need to give them something else that works well for them. Really excited to look at the patient admission experience, like the IntelliCare demonstrations today. That's, something I get excited about. And then we've still got some medication management, anaesthetic records sitting out there. And we have put bed management on the future slide, but this is a cool thing that people have got excited about, so I thought we'd put it up as its own slide. So just this year, probably 6 weeks ago, we've introduced, so using TrakCare bed management module, we spent a lot of time. I think we first looked at it, Tracy gave a demo of the bed management module, and it wasn't quite there, but it was so close. So yeah, my goal, actually I had our hospital manager is retiring this week, and I promised her that I'd be able to give her that bed board as a retirement gift. So it might be delayed a couple of weeks because there's a few people that would rather they were taking it home. But yeah, you can see this is what we've been using for our bed management, and it's actually a bit simpler than Excel spreadsheets. We kind of like being able to move people around and things. You'll see where my gender issues come from. 100 of our beds are single rooms, and yet you still get a blue or pink card. So moving away from that has been important. So this is what I've taken the patient information out of it. So this is our first sort of go. We've just put a presentation layer on top of the bed management module. Different colours, admissions, discharges, not going anywhere. I didn't pick a very good day because usually we can see clashes when estimated date of discharges change really easily. We also do a lot of transferring, and it supports our admitting through our admissions area. Remembering we're elective surgery, through our admissions area into the ward, then they might go to ICU, and we can have that all planned out and manage our bed management, and you can easily see where I can put a patient and for how many days I can put them there. So that's kind of been a good thing that we've been able to kind of look towards really optimising our use of TrakCare, like having it for 20 years. This was probably always sitting there, and getting the opportunity to look at it. So, yeah.
And again, looking at these now instead of looking at supporting it when it's not working, because we don't know how it's all configured and everything. So that's a really good thing moving forward. So yeah, we're very pleased to be into the position we are, and looking forward to the next 6 to 12 months, you know, as Erin said about IntelliCare and other initiatives as well. So yeah, that's us for today. Thank you.